Hello guys, today we're going to talk about the anterior abdominal wall and the peritoneum. So before we get started, here are the learning objectives. So in general, we're just going to go over the actual anterior abdominal wall. We're going to talk about the quadrants. We're going to talk about some of the muscles that are forming the anterior abdominal wall. We're going to go over the arteries, the nerves, amongst other structures that are part of it. So without further ado, let's just get started. So over here, we have to talk about the regions of the abdominal wall. And so for that, I have drawn this person chest and abdominal area to show you what are the quadrants. If you were an undergrad and probably you already took A&P, you probably remember this from your A&P course, where the quadrants is just two lines that intersect the area closer to the belly button. And so basically, we're throwing a line from the xiphoid process all the way down to the pubic region, and then we throw another line more or less at the level of the umbilical area. And so that gives us four spaces or quadrants. And so we're going to have two upper quadrants and two lower quadrants, as you can see there. And so based on anatomical position, this would be the right and this would be the left, right and left. And then all you have to do is add the letter Q, right? So that's going to give you an upper right quadrant and an upper left quadrant with a lower right quadrant and a lower left quadrant. And so basically you use that as an area or places where you can find certain, if you were a clinician, you would palpate those areas and you can think of the organs that are located on those quadrants. Similarly, you can be a little bit more specific, and instead of having or use quadrants, you can do what we call the regions. And so those are a total of 9 regions, okay, based on a couple of lines. So we're going to have two midclavicular lines or planes, which essentially those are two vertical planes that are going to pass through the midpoint of the clavicle, and it's going to be intersecting inferiorly with the anterior superior iliac spine, or ASIS, to the pubic tubercle. And so then you're going to throw two more lines, one that it's going to be your subcostal plane, a little bit more above the umbilical region, and you're going to throw a transtubercular plane, also known as the intertubercular plane. And so that is going to be, those are going to be horizontal planes or lines that are going to be, in the case of the intertubercular plane, that is going to be connecting the tubercles of the right and left iliac crests near the level of L5. Okay, and so that is going to give you a total of 9 regions. So you're going to have a right and left hypochondrium region, right? So I'm just going to draw an H here. Hypochondrium, it's because they're near the ribs. Chondrium, it's from cartilage, right? So we have in that area some cartilage that it's part of your costal cartilages. Then you're gonna have an epigastric region, epi above, gastric as in stomach, right, or digestive area. Then you're gonna have a right flank and a left flank. I believe some other books call that lumbar, and then you're gonna have the right groin and the left groin, and I think some books call it iliac regions. But for our textbook, Gray's Anatomy, this is how it's considered. And then obviously on the midsection, you're gonna have an umbilical region, and then inferior to it, you're gonna have the pubic region. right, more inferior to the umbilical region. And if you notice on this picture, um, you're gonna notice, I'm gonna put myself to the other side so you can see the picture where you can observe on each region, you're gonna notice certain specific organs. For example, the most obvious one, it's the epigastric region where you can see most of the um, stomach, right? You can observe over here the gallbladder. You can see your transverse colon passing through that epigastric region, and of course, parts of your liver. Now, your umbilical region, mostly it's going to be small intestine versus, for example, the right groin where you have the cecum, most of it, etc. So this is just regions to locate these specific organs. So I'm going to put myself back to where I was on the left. And we're going to talk now about the abdominal wall. So when you get into the cadaver lab, if you have a cadaver lab component, in our particular case we do, you are going to be removing the skin of the abdomen. And one of the first things that you're going to be noticing is that as soon as you remove the skin, as you observe right here, right on this cadaveric example, we're going to notice that we have two layers, right? The most upper layer is known as your Camper's fascia. This is the most superficial fatty layer. And so this one is going to be continuous with the superficial fat over the rest of the body, and it could be thick in some cases. Now, deep to the Camper's fascia, we have Scarpa's fascia. And this one, it's like I said, it's deeper. It's a membranous layer. It's going to be located on each side. And it's typically going to be fusing with the fascia lata, which is a deep fascia that comes from the thigh. When you get into the thigh region, you're going to see it. And so this one, it's going to be continuous also with the superficial fascia, also of the penis in males, and or in the clitoris of females. It's also going to be continuous with the dartus fascia, specifically the scrotum in males, and the superficial perineal fascia or Colles fascia. Now, in this picture, this is the cadaveric picture that I was mentioning, where you can see that right underneath or deep to the skin of the abdominal wall, you're going to notice Camper's immediately, and then you're going to see the outer rectus sheath covered by this membranous layer of the superficial fascia, which I told you is also known as Scarpa's. Now, right after you have dissected those, then you're going to find another layer, which is a layer of muscles on the anterior abdominal wall. And so typically we have a total of 5 muscles that we're going to observe in both male and females. I have one more muscle that I have to talk about, but it's only located in males. But for these muscles, 3 of them, they're going to be very broad and thin. Be very, very careful as you are dissecting this area because they're very, very thin. For those of you who remember on Gross Anatomy 1 when we were dissecting the neck, if you recall that platysma, how thin that was, this is exactly like that, almost like that, super, super thin layers. It depends obviously on the body, right? So on each side, you're going to notice that you have your external oblique muscle. Your external oblique on this particular picture has been cut, but you have some remaining over here. And if you notice, the external oblique has the fibers descending kind of like when you put your hands in a pocket, right? That's the pattern that this external oblique shows. Then deep to the external oblique, you will have the internal oblique, which you can actually observe right here. And the patterns of the fibers of this muscle are going to be opposite to the external oblique. So if the external oblique is kind of descending as if like you're putting your hands in a pocket, this one, it's typically on the opposite direction. And then you're going to have another muscle called transversus abdominis or transverse abdominis, in which that muscle, it's going to go in a more horizontal plane typically, and it's the innermost layer in this particular case. Now we do have another muscle. This one is located also on each side of the anterior midline. It's vertical, and it's the one that we call rectus abdominis. We also typically call it the six-pack, right? And we all have them. It's just that in some cases, some people have, like my one of my family members would say that he had a bag of ice on top of the six-pack to cover it, right, and preserve it. But so rectus abdominis. It's also very present by these tendinous intersections. In some people, we may see approximately between 2 to 4 and even 5 tendinous intersections. It just depends on each person. And then there's another muscle that I did mention before that I said that we have a total of 5 muscles. That is going to be your pyramidalis. Now, this muscle, as the name implies, it has the shape, the fibers have a shape of a pyramid. It's located more inferiorly in the lower part of your abdominal wall, and it's typically absent in about 20% of the people. And so medially, we're also going to notice this line right here that we call the linea alba. Let's talk about a little bit more about these muscles in general. So if you notice on this table, this is part of your Gray's Anatomy book, table 4.1. It shows you all the muscles of the abdominal wall. And you're going to notice that we already talked about the external oblique. So your external oblique, the insertion is going to be the lateral lip of the iliac crest. It also has an insertion in the aponeurosis ending in this midline raphe or the linea alba. And the innervation for most of these muscles in general is going to be the anterior rami of these thoracic spinal nerves. Typically, they go from T7 to T12, and it just depends on the level, right? For the external oblique, the functionality, it's typically going to be to compress the abdominal contents. Notice that most of your abdominal wall muscles have a similar function, right? They're all going to be compressing the abdominal contents. Notice your internal oblique does the same, your transversus abdominis does the same, and your rectus abdominis as well. Now, there are some differences in the functionality. For example, for your external oblique, this one is going to be flexing the trunk, and typically it's going to be doing the flexing, the bending of the trunk on the same side and turning the anterior part of the abdomen to the opposite side in comparison to your internal oblique, which instead it's going to be turning the anterior part of the abdomen to the same side, right? Your internal oblique has an insertion in the inferior border of the lower 3 or 4 ribs, but it also has an insertion in the aponeurosis ending in the linea alba and the pubic crest and pectineal line as well. So there are a couple of differences there in the insertion. Transversus abdominis specifically only does compression of the abdominal contents. It doesn't do typically anything else because it's the innermost layer. And this one, it's going to have an insertion in the aponeurosis ending in the linea alba, and it does have in the pubic crest and pectineal line. And over here you can notice that your rectus abdominis has an insertion in the costal cartilages, but also on the xiphoid process. So it does go pretty superior on the abdominal wall, reaching closer to the thoracic area. Now, your pyramidalis, the insertion is into the linea alba, and it tenses typically the linea alba. It doesn't really do much other than that. And here we can see on this picture, I'm going to push myself to the other side, where you can see some of these muscles that we have mentioned. You can see the linea alba more medially over here. And then you can see this other line that we call the linea semilunaris, right? Now, I told you earlier that in most of humans, we're going to have those 5 muscles, but in males specifically, there's one other muscle that we have to talk about, and this is the cremaster. The cremasteric muscle It's a muscle that is going to essentially retract the testes. So that picture that you see right here, that is the cremaster in males. And it has an insertion in the pubic tubercle and crest. And it's innervated typically by the genitofemoral nerve. Okay, when we get into the posterior abdominal wall, we are going to get into the details of the genitofemoral nerve later on this trimester. Now, I think this is an important thing to talk about because for your uh, clinical correlation, the cremasteric reflex is, oh, I kind of like this. I'm kind of like behind the slide, but you can notice here that the cremasteric reflex is essentially a reflex that is produced after you have stroke the upper medial side of the thigh, creating a contraction of this muscle and thus an elevation of the testes when the thigh is stroked. Now, this is important because when the cremasteric reflex is absent, it could be due to some neurological disorders or even a spinal cord function malfunction at the level of L1 in men. Typically, it's more active in children, but it could diminish with age. So that's something else to consider as well. Okay, moving forward, now we have to talk about the rectus sheath, because the rectus sheath is just formed by the layering of all of the aponeuroses from these different muscles that we just talked about. So it's the layering of the aponeuroses of the external oblique, your internal oblique. We also have the transversus abdominis muscles. And as they're coming together, they're creating this rectus sheath. And so it just depends on the level that we are on the abdominal wall. We are going to see some differences. So let's talk about that. Let's talk about this real quickly. So if you notice over here, first things first, the contents of the rectus sheath is going to be the rectus abdominis, the pyramidalis. If it's present, like I said, it was absent in 20% of the people. The terminal parts of the lower fifth intercostal nerves and subcostal nerve, as well as the superior and inferior epigastric vessels. So all of those are contents of your rectus sheath. And so it says here, upper 3/4 of the anterior abdominal wall, the aponeurosis of the internal oblique splits into two lamina. The anterior lamina joins the aponeurosis of the external oblique to form the anterior wall of the rectus sheath, and the posterior lamina joins the aponeurosis of the transversus abdominis to form the posterior wall of the rectus sheath. So I'll show you in a second what this is talking about. And then it says here, on the lower 1/4 of the anterior abdominal wall, the three aponeuroses pass anterior to the rectus abdominis muscle to form an anterior wall of the sheath. And it says there's no posterior aponeurotic wall. At this level, the rectus abdominis muscle is directly related posteriorly to the transversalis fascia. So I'm just going to go back here for a second to show you what that means. So if you take a look at these pictures, first things first, this is a transverse section of the anterior abdominal wall only with these muscles and the rectus sheath, as well as the peritoneum. So from anterior to posterior, you can notice the external oblique, then we have the internal oblique muscle, and the transversus abdominis. More medially, you'll see the rectus abdominis, and then more posteriorly, the transversalis fascia and the parietal peritoneum, more deeper in this particular case. But if you look at the rectus sheath above an area that we call the arcuate line, we're going to go into the arcuate line in just a second. But if we take a look at this area of the anterior abdominal wall above the arcuate line, you're going to notice that this rectus sheath, it's kind of like creating, I call it kind of like creating a sandwich, right? I call it a sandwich because you have your rectus abdominis sandwiched in between the layers of the rectus sheath, right? Now, below to that arcuate line, so we will talk about the arcuate line in a second, but below that arcuate line, you're going to notice that now all of the aponeuroses of those muscles are going to only run more anterior to the rectus abdominis, and posteriorly you won't see it. So at this level, below the arcuate line, you're going to see that this is kind of like a blanket on top of the rectus abdominis. So above arcuate line, we can call it, I call it a sandwich. Below the arcuate line, I call it, we're just like putting the rectus abdominis to sleep because you're just putting a blanket on top of it, right? That's just my way to see it. You don't have to see it that way, but so that's what I was trying to say with the arcuate line. This is just a very curved line that is going to basically mark the lower end of the posterior aponeurotic wall of the rectus sheath. So that's the importance of that arcuate line. And make note that you will see it, if we see it in the lab, that could definitely be a point where you're gonna get tested on the lab practical. So this is located, like I said, halfway between the umbilicus and pubic symphysis, and like I said, inferior to the arcuate line. It says here posterior aponeurotic wall of the rectus sheath is lacking, right? So we don't see it, like I said, kind of like putting a blanket on top of that muscle. Okay. So here you can see it again, and actually, if you notice, hopefully you can see it on your video, on your screen. You can see it how right here is the term, the very end between those levels. So that's gonna be the actual arcuate line. This part right here, you can see that it even looks a little bit transparent in a way, right? Okay. Oops. Okay, and on the most deeper layer that we have right here, it's going to be the peritoneum, right? Because the peritoneum is that layer of serous membrane that is protecting at this point your organs. Once you pass through these muscles and that rectus sheath, we are going to be entering the area of the abdominal cavity, right? So this is where we're going to be seeing that peritoneum. It's like I said, it's a serous membrane, and that lines the walls of the abdominal cavity, providing very complete or partial covering for these organs. We're going to be seeing and learning that some of these organs are considered intraperitoneal or retroperitoneal, or secondarily retroperitoneal, right? So the peritoneum lining walls is the parietal peritoneum, and then you have the peritoneum covering the viscera, which is what we call the visceral peritoneum. Okay, another very important structure, you already know in gross anatomy, that we have to look for blood vessels. And some of the most important blood vessels that we're going to be looking for, they're called superior epigastric artery and inferior epigastric artery. So when you start reflecting these muscles, you're going to be reflecting your external oblique, internal oblique, and your rectus abdominis muscle. So you're going to notice these two arteries deeper, on the deeper side of your rectus abdominis muscle. And so the superior epigastric, this one is a terminal branch of your internal thoracic artery, which, if you recall, we saw that when we were doing the dissection of the thorax, running parallel to the sternum, right? And that branch is a branch of your subclavian artery, if you recall, right? So your superior epigastric artery, like I said, a terminal branch of this internal thoracic artery, it's going to be descending posterior to the rectus abdominis within the rectus sheath, and it supplies the upper central part of the anterior abdominal wall. So it's very super important artery right here. And it anastomoses eventually with your inferior epigastric artery. So you can see the inferior epigastric artery right here. This one is going to be originating from the distal part of the external iliac artery, and it just above that inguinal ligament. And so it's going to run superiorly and medially, and it's going to be entering the rectus sheath, and it ascends posterior to the rectus abdominis. It is also going to supply the lower central part of the anterior abdominal wall. And like I said, it anastomoses eventually with your superior epigastric artery. So those two arteries, super, super important to find and locate. They can definitely be part of your test. Now, the other important arteries that we may or may not see, it depends on the cadavers, right? We sometimes don't see them very well, or they're very tiny. But we have these 10th and 11th posterior intercostal arteries, and subcostal artery and lumbar arteries. You can see here on this picture, that's going to be your 10th posterior intercostal, 11th posterior intercostal, and your subcostal artery. Those are typically running more laterally and in the same fashion as your external oblique, right? And they're going to be supplying that lateral part of the anterior abdominal wall. And we also have a deep circumflex iliac artery, which you can see here on this picture. I'm going to move myself to the other side so you can see it. This is your deep circumflex iliac artery, which is originating from the distal part of the external iliac artery. Super important artery over there. Other arteries that we could observe as part of your anterior abdominal wall is the cremasteric artery, which is a branch of this inferior epigastric artery, and it's going to be irrigating the cremaster muscle in males. So it's only located in males. You will not see a cremasteric artery in females. You also have a superficial epigastric artery, which is a branch of the femoral artery, this one running towards the umbilicus, anastomos in there with the inferior epigastric. You also have your thoracoepigastric veins and superior and inferior epigastric vein and lumbar veins as part of the blood vessels on this area. Okay, now we have to talk about the innervation of the anterior abdominal wall. And I think we have already seen part of this before when we were discussing some of your dermatomes, right? If you recall, one of the major things I've mentioned before is that your thoracic innervation and your dermatomes are leveled down, right? So if you recall, nipples typically is T4, and I remember telling you guys that belly button is T10, right? So here we have it, the anterior rami of the thoracic spinal nerves are innervating all of your anterior abdominal wall from T7 all the way down to T12. T12 is also known as subcostal nerve, which we are going to definitely observe it more clearly when we get into the posterior abdominal wall, when we do that dissection after removing all of the organs for the second half of the trimester. You will definitely see the subcostal nerve. And then in addition, T5 and T6, that could also supply the upper parts of the external oblique muscle. So you may have some overlap coming from the thoracic part of these nerves. Okay, so they are supplying the skin and the muscles of these inguinal and suprapubic regions. They are innervating all of the anterior abdominal wall, and then over by the inguinal and suprapubic regions, you do have parts coming from L1. So there's also an overlap there between T12 and L1. Okay. Another important thing that we have to talk about is the wall lymphatics. I know that lymphatics is usually not one of the favorite topics, however, super important because lymphatic drainage, it's super important, especially in clinical correlations like cancer, for example. So the lymphatic drainage of the anterolateral abdominal wall is going to be by the superficial lymphatics above the umbilicus that will pass in the superior direction towards your axillary nodes. So those lymphatics are going to be draining over by the axillary nodes. And the drainage below the umbilicus is going to be passing in an inferior direction towards the superficial inguinal nodes, which I added here on this picture. Let me move myself to the other side so you can see it on the screen. That's your superficial inguinal nodes. And so you also have some deep lymphatics that are draining towards in the deep arteries of the back, right? Those lymphatic nodes that we have in that area. Um, I have added some of these questions that you can read at home, but for purposes of you studying, here we have like a patient expresses pain in the epigastric region. Which organ could be affected if it's on the epigastric region? There's something to give you a little bit of to think. And then another question I designed here for you guys: a patient was sewing when she accidentally stabbed herself with a needle in the anterior abdominal wall, laterally above the arcuate line. So, which of the following layers under the skin was the second one the needle went through from anterior to posterior? So, in here, I'm giving you the answers. For the one, it's letter D. For the second one, it's letter C. Okay. Other important things that we have to talk about. I know Dr. Everett likes to talk a lot about the embryological development. Let's talk a little bit in here as well. So for here, you're going to notice after this, I'm gonna stop and I'll make another videos because I know we're already at 30 minutes here. So last but not least, on this first part of the video, the embryological development here of the inguinal canal has to start with the processus vaginalis transformed into a tubercular structure, which forms the basic structure of the inguinal canal. And so typically that is led by this gubernaculum right here. The gubernaculum is the structure that leads the movement of, if it's in males, the testes, right? The testes, as the testes are descending. And then in females, obviously the ovaries. But in this particular case, gubernaculum is that structure. So the descent of the testes into the scrotum or the ovaries into the pelvic cavity, it's going to depend greatly on the development of the gubernaculum. And here's the processus vaginalis that I was mentioning about. And so that gives us the inguinal canal, which is a very, it's an oblique passage, very, very weak, by the way. The inguinal canal is a very weak area through the lower part of the anterior abdominal wall. It's typically immediately above the medial part of the inguinal ligament. And so some of the openings here you're going to see the deep inguinal ring and the superficial inguinal ring. The contents of the inguinal canal typically depends on male versus female, but typically you're going to see a genital branch of the genitofemoral nerve. In men, the spermatic cord and the round ligament if it's in females. Additionally, in both sexes, you're going to see the ilioinguinal nerve passing through part of that canal. And in males, just to recap, the spermatic cord is just formed by the structures that are between the testes and the abdominal pelvic cavity. When we get into the pelvic area, you're gonna learn more about the spermatic cord and the ilioinguinal nerve. And in females, the round ligament of the uterus, which is a fibrous cord extending from the uterus to the labium majum or majorum. And then you're going to notice the genital branch of the genitofemoral nerve and the ilioinguinal nerve. The walls include an anterior wall made by the aponeurosis of the external oblique, the posterior wall, which is by the transversalis fascia, which I think I'm including some of those here. Here's transversalis fascia. The roof of the superior wall by the transversus abdominis and internal oblique muscles. Here's transversus abdominis. And the floor or inferior wall is going to be medial 1/2 of the inguinal ligament on this area. And the contents of the inguinal canal, like I said, spermatic cord, round ligament, and this genitofemoral nerve. In males, here I have included the spermatic cord details. Some of the things that you're going to see in the spermatic cord include the ductus deferens, testicular artery, that pampiniform plexus of veins, super important, cremasteric artery and vein, genital branch of genitofemoral, and we have some innervation as well and lymphatics in there. Most important, you also, the ductus deferens, like I said, super important structure there. Now, why is this important? Because of hernias, right? Like I said before, this is a very weak region of the human anterior abdominal wall, and it's prone to inguinal hernias. And so there's two different types of inguinal hernias, which is the protrusion or passage of the peritoneal sac with or without abdominal contents, which usually, when you say abdominal contents, you have to think of intestines, quite literally. Is usually either the small intestine, and in some cases, large intestine could be, but mainly small intestine, passing through that area, right? In males, it could go all the way down to the scrotum, right? And I'll show you a picture in a second, but there's two ways in which this could happen. There could be an indirect hernia through the deep inguinal ring, which you can see right here, or direct hernia. Let me put myself to the other side, so that you can see the picture, which is through the posterior wall of the inguinal canal, in which case those contents are going to be entering that area. And so in here, let me move myself to the other side so you can see this coronal CT showing a large inguinal hernia with parts of the large and small intestines in there, like I told you. Okay, so we're gonna stop here, and I'll see you in the next video.